Okay. Thank you, everybody, for joining us, the Alberta Association of Optometrists, on your lunch hour to learn about optometry in Alberta. Before I introduce our presenter, Dr. Christy Franco, a few quick housekeeping items. We'll have time for questions at the end. So as we go through, just use the Q&A function to drop your questions in, and we will answer them at the end. And also, there'll be a survey that pops up when the webinar ends. If you could take a few minutes to answer the survey, that would be really helpful for us to continue offering webinars like this that the industry finds valuable and relevant to their practice. So without further ado, I will introduce our presenter. Today, we are learning about optometry in Alberta with Dr. Christy Franco. So sorry. She practices in Airdrie at a comprehensive optometry clinic. She is the lead optometrist of the vision therapy clinic at Airdrie Family Eye Doctors and is one of the main advisors for the vision after stroke care pathway that's being developed in Alberta. Dr. Franco strongly values collaboration with other healthcare professionals and is a council member for the Alberta Association of Optometrists. Thank you, and off to you, Dr. Franco.
Amazing. Well, in that case, let's get this shared here. Quick thumbs up, Megan, you can see everything you can see my screen there? Yeah, perfect. Okay. Well, thank you so much for that introduction. That was very nice. I appreciate that, Megan. And yeah, so thank you again, just to everybody who's joining us. This is wonderful to have you all with us today to take this time out of your day and to talk about optometry here in Alberta. So let's jump in. We have got a lot to cover today. Bear with me because we're going to go through things pretty quickly. You heard most of this already. I want to just draw your attention to a couple little things. In Airdrie, I do practice at a full scope optometry practice. What I mean by that is that we do everything that is within the scope of optometry at that clinic. So everything that we're able to do, we will be practicing at that clinic. And I am now the president-elect of the Alberta Association of Optometrists. I do also have a vision therapy clinic at the Airdrie location, so we do a little bit more about some specialty eye care, not just the primary care at our clinic. Couple quick disclosures to go through. I don't have anything specifically myself. However, I did receive some financial support, so that is potentially a conflict of interest from the Alberta Association of Optometrists for this talk. This talk also received financial support and in-kind support from the Alberta Association of Optometrists. I do not talk about any pharmaceutical products or medical devices in a way that's promoting them in this talk, and there are no treatment or monitoring recommendations that are made outside of the evidence-based standards of care, standards of practice. So what are we going to talk about today? Obviously, an overview of optometry and what we're able to do. We're going to talk about the services that we provide here in Alberta, from routine to emergency care, as well as some of the specialty eye care that we can provide. We're going to talk about common eye conditions that we're seeing, as well as some of the things that we see in the eye from systemic concerns, whether that's a disease or a systemic medication that a patient is taking. We're going to talk a little bit about Alberta healthcare coverage, as well as some of the changes that took place recently, and how to refer to and co-manage with an optometrist. So let's jump right in. What is optometry? Well, one thing I find a little bit confusing for people is that there are 3 different O's in the eye care world. So we have opticians. These are the people that are the experts in glasses. Some of them also can do prescribe and fit contact lenses. But they're the person you're going to see. You bring your prescription to them and say, hey, this is what's going on. And they're going to find you a frame that works, as well as lenses that are going to suit you and suit what your prescription is, to make sure that you're comfortable wearing those glasses. An optometrist, I like to say, is the family doctor of the eye care world. So we are your primary eye care providers. We're coming in, we really are front line in terms of eye concerns. People are coming into us. We are managing ocular health concerns. We're managing systemic concerns that have ocular complications. We're prescribing glasses and contact lenses. We can also prescribe medications. And then when we go to that next step, your ophthalmologist, these are your specialists. So like your cardiologist or your endocrinologist, your surgeon, this is the specialty care that we have, that next step up in the eye care world, that we will be using when we really need those services. An optometrist, a doctor of optometry, does an undergraduate degree first. I have on here 3 or 4 years, and that's because most schools require you to have that full undergraduate degree first, but a few will take you after 3 years. The Doctor of Optometry degree itself is 4 years long. It is similar to general medicine for that first year, year and a half. And in saying that, what I mean is that we do general pharmacology, general anatomy, like whole body anatomy and neuroanatomy. We do general immunology, general histology, we do microbiology, all these different things before really honing in and focusing more on the eye itself and its role in the rest of the body. I have on here the art of prescribing glasses, and that's because it truly is an art. What we measure is not what we prescribe. What are they currently wearing? What's in their glasses? What have they got going on? You know, do they have diabetes? Have they had a concussion? It's not just what we measure, we prescribe. We're, of course, learning about ocular health and ocular health in relation to the rest of the body. And our internships, we have rotations and working rotations throughout this degree as well. In order to practice in Canada, it is now a new change. Every province now requires that you have the Canadian board exams, that you've passed those exams to be able to practice in the provinces. A residency and a fellowship are optional in optometry. I want to draw your attention here. This is a wonderful definition from the Alberta College of Optometrists, and I've just bolded one little area because it really does encompass what we're doing. We are educated and trained to examine, assess, measure, diagnose, treat, manage, and correct diseases and disorders of the human visual system, the eye, and its associated structures. That is quite the mouthful, but it really does encompass everything that we're doing. If you think of what our amazing colleagues in the general practitioner, family doctor, nurse practitioner world are doing, it is a lot, and we are really doing a lot in the optometry room as well. What can an optometrist in Alberta do? We've talked a little bit about this. Of course, prescribe glasses, fit and prescribe contact lenses. One thing I want to highlight is that we can prescribe all medications, any scheduled drug, so any Schedule 1 or Schedule 2 medication, an optometrist can prescribe, whether that is topical or oral. We can also monitor and manage ocular diseases, and then when we need to, we'll be sending off to somebody to do that more, that next step of care if it's required. We do provide some advanced treatments. We talked a little bit about some of these, but maybe advanced dry eye, advanced binocular vision, some low vision, some specialty glasses or contact lenses. And we are co-managing. We're seeing one piece of the body, but we are not experts in everything. So we are co-managing with every other healthcare practitioner that's out there. And of course, ophthalmologists as a big piece of that as well. Our role here in Alberta, I mentioned before, we really are the front line of eye care. We are providing the vast majority of primary eye care here in Alberta, whether that be a routine eye exam, a medically necessary exam like an urgent or emergency care, or something specific for diabetes, let's say, or other concerns. We could be doing specialty services. We've touched on some of those, and we'll talk more about those later. We are also doing a lot of surgical co-management. So when an ophthalmologist does a surgeon, that patient often comes back to us afterwards so that we can monitor the progress and how they're healing and what's going on, and then send letters back and forth so we make sure the patient gets the care that they need. And that doesn't just go with our ophthalmology colleagues, this inter and intradisciplinary care. That's because of those specialty services that we have, some of the special interests that optometrists have. Not every optometrist is practicing that, but if a patient needs it, we'll actually be referring to other optometrists to make sure that that patient gets that care. So what's included in a routine eye exam? This is an overview of what's going on in their vision. Do you need glasses? What's your visual acuity? No, that's the thing that we all think of. Do you need glasses? But also, how are your eyes working together? This is on a surface level. You've heard me already say a couple of times binocular vision as a special interest for optometry. In a routine eye exam, every optometrist is checking the ability of the eyes to work and move together, to communicate with the eyes and the brain, but on a more surface level. And if we need to deeper dive, that's where that special interest comes in. And the last one, are your eyes healthy? So this is the front of the eye, the inside of the eye, and overall around the eye, what is going on? In an adult, and I have adult in quotations here because really this is like 8 and older, 7 and older, depends on the child. Definitely older children, our adolescents, our young adults, our adults, this is what we would be doing for them. It starts off with a history, as it does for most of you as well. What's going on? Not only with their eyes, but with their systemic health. We want to know that personal history as well as their family history. If they have a history of macular degeneration, we want to know about it. If they have a history in the family of GI issues, we want to know about it so that we can look for the things that are happening in the eyes that are related to that. Visual acuity, this is the 2020, how well do you see kind of thing. Of course, we're checking on that as well. Again, that general binocular vision assessment, how well your eyes working together, communicating with the brain. Do you need a prescription for glasses and contact lenses, and what is that? And then that ocular health assessment, I talked about this. It's everything throughout the eye. And I wanted to show you because this, although this is a general eye exam, what we're using to do this eye exam has really changed in the last 10 years. We have a lot of technology now at our disposal to be able to provide a really high-tech, amazing eye exam. And so I have this image here. This is one of the instruments that we have at our clinic. You can see the iris here. That's just a diagram, but this is a picture of my eye. The diagram is just the iris. The rest of it is actually the picture of my eye. And this is an imaging technology that we have called the Optomap that actually takes a 200-degree picture of the inside of your eye. So when we're looking inside people's eyes, we're looking through the pupil, we're looking to the back. This photo gets zoomed into a little bit more, but if I stopped or if I didn't use this specific little animation, we would actually be seeing to 200 degrees into the back of the eye, which is pretty fantastic to be able to look that far, especially with children, which it's a lot harder to get them to look in different areas and hold that gaze for us to get a look. So speaking of children, we can start a routine eye exam at 6 months old, and that is when they should be coming in, is somewhere between 6 and 9 months for their first eye exam. You can see here that everything is the same. We're just doing it in a different way. We're using more objective measures to be able to look inside the eye. And, I'm not going to ask a 1-year-old, what do you see on the screen? However, some 2-year-olds and 3-year-olds might be able to do some of this with us. So if I go to the next one here, you can see in the bottom left corner, there's a picture of some other pictures. And so we don't always use letters. We'll use pictures and numbers and other things. I'll sometimes do like little matching games with them to figure out what it is that we're seeing. You can see those photos in the bottom right. That one, far right one, is my eye again, that 200-degree image versus a classic fundus photograph, which is a little bit smaller. It's about 45 degrees, and you can see that in the middle on the bottom. Up above, we've got other technologies and things that we're using to look in the eyes of children. We can actually assess prescription without asking which is better, one or two. I can do that for adults as well, but it's a little bit easier to, consult your brain and figure out what feels best for you. But for children, we don't have that opportunity. And so we're checking things in a little bit of a different way. On the top right, this is another new piece of technology that's available to us. This is called the Maya, and it's actually measuring how long the eye is to help us determine what's going on with myopia progression or progression of nearsightedness for a patient. We're going to talk a little bit more about that in the future of this talk. Sorry, coming soon. So when should you come in for a routine eye exam? I mentioned that your first exam should be somewhere between the ages of 6 and 9 months. The next exam should be between 2 and 5 years of age. After that, you should be coming in every single year while you're in school. We want to be getting on top of things and catching them early before they have a major impact on your schooling and your learning. Adults 20 to 64 should be coming in every 1 to 2 years. And it's said this way because it really depends on what we're looking for. Is there something that we're monitoring and we really need to be seeing you once a year? Do you wear contact lenses and we need to see you once a year? What else is going on? And then once you hit that magical birthday of 65, we want to be seeing you once a year again. Now that risk of having something going on in the eye is a lot higher. And again, catching it early is key. So the faster we can get you in once a year is better. Now, this is a general guideline. Of course, if we are seeing something and we need to see that patient come in a little bit sooner, this routine schedule might be different. We might be seeing a child at 1, at 2, at 3, at 4, and then at 5, and so on. We might not be doing it in this schedule here. And also, this does not include things like dilated eye exams or medically necessary appointments where we're watching something specific for a patient. This is just the routine eye exam, how often you should be going in to see the optometrist. All right, let's get into some common eye conditions. This is going to be fast. If it hasn't been fast already, it's going to be fast now. We wanted to get in as much as we could, so let's rapid fire some of the common eye conditions that optometrists see every single day and that I'm sure all of you have heard of or dealt with as well. So, first up, the big one, cataracts. Unfortunately, hate to break the bad news to you, but this is something that every human on the planet will get at some point in their lives. Whether or not we need surgery for that cataract is a different story, but everybody will develop cataracts. And that's because this is a change in the proteins that are happening inside the lens of our eye, and that leads to the clouding of the lens, which will happen for all of us. You can see under causes there on the far right, age is the number one factor. Before we move into the causes, let's talk a little bit about symptoms. Blurry vision, we might have glare, we might have difficulty with night driving, age, and again, beside that, you see UV damage. So UV damage for sure, we know makes those cataracts happen a little sooner, and most of our UV damage happens before we're 18. So this is something that we really want to be wearing sunglasses even when we're young, and it has a lifelong impact for us. Systemic conditions, diabetes, for example, can cause earlier cataracts, but that's not all. Autoimmune conditions, chronic kidney disease, lots can affect cataracts. Medications, steroids are the really big one. Amiodarone is another one, but steroids are the biggest, whether that is orally or topically. So I have it under here as like a systemic thing, but topical steroids can also cause cataracts. Any kind of ocular trauma, we can get a traumatic cataract, and then we can also be born with cataracts. There are certain congenital conditions that are associated with cataracts as well. Optometrists are monitoring and managing cataracts. So they're doing prescription changes to make sure that patient can see as best they can until that point where we are referring to an ophthalmologist to get that treatment, to get the cataract removed and a new lens put in. And then afterwards, that patient is coming back to us for that post-surgical care. Dry eye. I think if I could see all of you and I asked who has dry eye, at least, a little bit, everybody here would put up their hand. We live in lovely, wonderful, dry Alberta. And so dry eye is really, really common. And, we joke a little bit about it, but actually this can be very, very serious. In dry eye, there are multiple causes that happen, but, overall, we lose the homeostasis of the tear film. We either don't have the right quantity of tear film or we don't have the right quality of tear film. And it's really the quality that's the bigger one. That leads to ocular surface inflammation and damage. And the further that this process goes along, the more difficult it is to treat and the harder it is to get that patient back to baseline, back to where they're feeling, where we can, end up with some permanent damage here. That can actually be neurotrophic. So you can see under symptoms at the bottom there, no symptoms. So somebody who's got mild dry eye might not have any symptoms. We can see it on their eye, but they don't have a lot. But also somebody who's further along might have neurotrophic damage. We would call this neurotrophic keratopathy, kind of falls similar to dry eye, but maybe a bit different, but they might not have any symptoms either. And that's a lot more serious now. Our risk of infection and our risk of other changes a lot higher, vision loss a lot higher. In general, our symptoms of dry eye, we've all experienced these, the sandy, the gritty feeling, the watery eyes, believe it or not. That happens when we don't have that right quality of tear film. A signal goes to your brain that's like, mayday, mayday, something's wrong. We send tears, but not the right kind. Burning and stinging, we might have itchy eyes, we might have fluctuating vision, and this tends to be fluctuating vision moment to moment. Allergies absolutely related to dry eye. If we move over to the causes side there, this is a cycle. So if your eyes are dry, you're more prone to have irritation from allergens, which makes your eyes more dry, and so on. Lifestyle environment, I'm talking to you on my screen. You are all looking at your screen as well. For sure, the more screen time we have, the drier your eyes are. You just don't blink as often. But also your environment. Is it a dry, dusty environment? What are you doing throughout your day? How are you using your eyes? Blepharitis, the buildup of stuff, bacterial byproducts, and other things around your eyelashes. This irritates our tear film. This irritates our eye. This is definitely contributing to dry eye. Systemic conditions, autoimmune, your whole body is pro-inflammatory. Your eyes are also pro-inflammatory. One of the things that happens from that is dry eye. Medications, psychiatric meds I have on here, but really anything that's impacting any of the neuronal signaling that's happening to make sure that our dry eyes or our tear film is staying stable can impact our dry eyes. And then hormone changes, unfortunately, also cause some effects here. So hormone changes, think of these as the natural hormone changes that are happening, but also our patients that are maybe undergoing certain hormonal treatments, they might end up with dry eyes as well. There are a million and one different treatments for dry eye. I joke with my patients that I have a kitchen sink I can throw at them for dry eyes. But really, as optometrists, we want to be looking at this patient. We want to determine the underlying cause of this dry eye. Remember, quality or quantity. And when it's quality, what is the problem that's going on? So that we can pick and choose the correct treatment for them to get them feeling better right away and not just band-aid the situation with an artificial tear. AMD, age-related macular degeneration. You might have heard of this before as ARMD. We kind of drop the R typically now. It's just AMD. This is when we have waste buildup at the back of the eye, the macula, the center part of the vision. And because of that, we have reduced central vision. The majority of the time, this is dry macular degeneration. So we're not seeing the new blood vessels that form in wet macular degeneration. In wet macular degeneration, we get fluid and blood leaking into the back of the eye, and that's when we're relying on our ophthalmology colleagues to get some injections into that patient's eye and make sure that they can keep their vision for as long as possible. In the early stages, especially the dry stages, we do not have any symptoms, but that does progress, and then we can end up with blurry or distorted vision. That's not correctable with glasses. We can get it to a certain point, but imagine that that lens is here and the retina is over here not doing so great. It doesn't matter how wonderful the light is coming in. If it hits a retina that's not seeing as well, we can't necessarily get that patient seeing any better. As dry macular degeneration progresses, we might actually be missing areas of our vision as well. Risk factors, age, number one, it's in the name, that makes sense. Smoking is the number one thing that we can do to help our patients with progression is to have them stop smoking. That is the biggest thing for macular degeneration. Family history certainly plays a role here as well. UV exposure potentially has some things here. Cardiovascular disease, same thing, possibly a risk factor. For sure, limited physical activity and poor diet. If your body isn't being given the nutrients that it needs, your eye is also not being given the nutrients it needs. This is also something that we will be monitoring and managing with supplements, with lifestyle changes in the dry stages. And as we get, or if we progress to that wet stage, that's when we're involving our ophthalmology colleagues. It is really exciting. There's a lot of newer treatments coming for both dry and wet macular degeneration that could potentially change the game here and really help our patients so that they're not, getting this sentence of vision, permanent vision loss at whatever age that they're diagnosed. Glaucoma. I think this is another big one for a lot of us. In optometry, we call this the silent thief of sight. I think in general, when I get a lot of referrals, I hear like, oh, they feel pressure in their eye and something like that. But a lot of times we actually have no symptoms of glaucoma, and that's why it's called the silent thief of sight. So let's dive in a little bit here. This is damage at the optic nerve that is progressive. The diagnosis takes time because glaucoma tends to be, not always, but tends to be a slowly progressing condition. So this is something where the optometrist might actually be monitoring for a year, 2 years, 3 years before they say, yes, this is glaucoma and initiate treatment. It is characterized by visual field loss. However, we have a lot of newer technologies now that are allowing us to detect glaucoma before that visual field loss is at a point where it's impacting the patient. There are also various kinds of glaucoma. We're going to touch on two of them here. So let's go to symptoms. Under primary open angle, this is the vast majority of our glaucoma patients. The pressure in the eye is higher with this, but it's not so high that the patient can feel it. Typically, they have no idea. They have no symptoms at all until they have tunnel vision because the glaucoma has progressed so much. So this is one that we really, really, really want to be watching, whether that's a primary risk because of family history or they have something else going on in their body that's increasing their risk. Angle closure glaucoma is the big scary one that we all know of. This is when the patient feels a lot of pressure. They've got pain, they have a red eye, they have a headache, they feel nauseous, they probably have halos and stuff around all the vision is just not good. And this is an emergency situation. So we absolutely need to break this angle closure. This means that the drainage inside the eye is blocked. The pressure has spiked suddenly in the eye, and that's where the pain and nausea comes from. And the pressure tends to be a lot higher than it would be for our POAG or primary open angle glaucoma patients. The risk factors, elevated eye pressure. Of course, if the pressure is high, we're more likely to have damage, but we can have glaucoma with normal eye pressure as well. Family history, increased age, ocular trauma comes back again. Not only can it cause a cataract, it can also increase our risk of glaucoma. Systemic conditions, cardiovascular concerns, high or low blood pressure, if it's just imbalanced, heart conditions, Raynaud's phenomenon, Raynaud's syndrome, anything like that can actually cause or increase your risk of glaucoma. Medications as well. I have calcium channel blockers here. I probably should have a question mark beside that. Depending on the study, some have said it's actually maybe a bit neuroprotective, but also others have found that it's damaging. So, caution with a calcium channel blocker. What's going on and do they maybe have glaucoma? Early treatment here is key. We can detect this so early, and if we can treat it early enough, we hopefully never get to the point where that patient is having any visual impact from their glaucoma. Drops and lasers are our first line treatment for this. All right, I wanted to talk about myopia or nearsightedness. This is when you need glasses to be able to see far away. So you take your glasses off, up close is clear, far away is blurry. And this is a disease. We used to think of it as just needing a pair of glasses. However, the needing the glasses piece of things is actually a symptom of the disease, which is the eyeball growing too long. The eyeball continues to grow and grow and grow and grow, and it doesn't stop. But we don't make more of what's inside of our eye, we just stretch it really thin. So, risk of holes and tears, maculopathy, changes at the central part of the vision, cataracts, early cataracts, all of this is way higher in those of us that have a higher prescription, a higher nearsighted prescription, than somebody who's not. So, myself, I'm a minus 6.5, for example. My risk is significantly higher for all of those things. Hide behind contact lenses. What is the description? We just talked a little bit about that. There is also the potential that the front of the eye is too curved. This is less common. This is not our kind of classic representation of myopia or nearsightedness. Distance blur is our symptom. You can't see things far away. Risk factors, genetics. We used to think, hey, it's just genetics, you're going to get it. But no, it is a genetic predisposition, not a genetic guarantee. What has a bigger role to play are the lifestyle factors. Are you doing a lot of close work, prolonged throughout the day? And are you maybe not going outside, not using your eyes for some distance tasks? This is where screens come in. We always think of screens as the bad guy. It's not the screen itself, but it's how long we look at it and how close we hold it. Binocular vision also plays a role here. If there is something going on in your eyes, binocular vision wise, they're having a hard time working together. That seems to increase our risk and increase the progression of myopia. We are very, very fortunate here in Canada. We can access a lot of treatment options for this. We can use specialty lenses, specialty contact lenses, drops as well. There are some drops out there, maybe not quite as effective, but our other more effective treatments can slow progression by around 50%. So myself, I'm a minus 6.5. I could be a minus 3.25. Not only is that amazing, I can see so much better, but my risk of all of those scary things that can happen way lower as well. So big, big thing. And this is something that we're looking for in children in particular. All right, if that wasn't rapid fire enough, let's do a little bit more. We're going to talk about systemic health and the eye. We tend to think of eyes as these little orbs floating in the skull, and they're just kind of doing their own thing and they're not connected to anything else. But really, we know better. The eyes are truly connected to everything else, and they are a window to what's happening everywhere else in our body, a window to that systemic health. So, what are the things that happen in our bodies that we often see in the eyes? And this is just a small piece of the things that we see, but maybe some of the more common ones. Cardiovascular disease, high blood pressure, atherosclerosis, heart disease, anything that's cardiovascular that's going on in the body, we can see the effects of that in the eye. Diabetes type 1 and type 2, this we all know really well. Autoimmune conditions, so rheumatoid arthritis, IBS, Crohn's. I mentioned earlier that these things put our body in a pro-inflammatory state, and that bleeds over into the eye as well. It's not just dry eye, but it's uveitis and other concerns. Sleep apnea. So this is one that we think dry eye, they have to wear a mask maybe at night. Dry eye is one, but also the risk of glaucoma increased with sleep apnea. Atopic dermatitis, psoriasis, dry eye is the big one associated with this. There are some other things that can happen here as well, but for sure dry eye. Thyroid problems. I've listed it as problems and not the differently because it could be hyper or hypo. It doesn't matter. There is an imbalance in the thyroid. We are at risk of Graves' eye disease. MS, multiple sclerosis, this is another one that we see very often. Unfortunately, the patient has a sudden, complete loss of vision in the eye. It is typically painless, but we're seeing it. And then, of course, we're going to get that patient into the right hands. Metabolic conditions, anytime that there is an issue in the body with a conversion of the food to the energy, if that's disrupted in any way, we can see that in the eye. So Fabry disease, for example, affects our corneas and we get some buildup there. Neurofibromatosis is another one that isn't on here, that we can sometimes see as well. I could go on and on and on. But I want to quickly draw attention to diabetes because this is something that we all are monitoring and managing in different ways. So let's take a little bit of a closer look at diabetes here. When we think diabetes, we all jump to, when we're thinking eyes, we all jump to diabetic retinopathy. But I really, really want to stress the importance that diabetic retinopathy is only one small piece of what's affected in the eye when it comes to diabetes. The cornea, the lens, the retina from diabetic retinopathy, and the optic nerve are all impacted by diabetes. So when an optometrist is seeing a patient to monitor for diabetes, the diabetic retinopathy is the one thing that we're watching for, but actually there's a whole bunch of other things that we're looking for as well to make sure that this patient is doing okay. We might have some blurry vision with a patient with diabetes, especially if they're uncontrolled. And this tends to be fluctuation day to day as opposed to moment, like with dry eye, unless the patient has dry eye from diabetes, in which case, then they're going to be getting the moment to moment as well. We might have blurry vision just in general. It's a sustained blurry vision. Dry eye, I mentioned, but maybe none. This patient might have no symptoms. Ocular conditions that are related to the areas of the eye. So in the cornea, we can get diabetic keratopathy. This is a neurotrophic keratopathy. Just like we get neuropathy in the other extremities of our body with diabetes, we get the same thing happening in our corneas. They cannot feel their corneas, therefore their body doesn't produce the proper tear film. We get early cataracts with diabetes, the diabetic retinopathy, of course. We can also get non-arteritic ischemic optic neuropathy. You don't need to know what that is, but we have a neuropathy happening at the back of the eye that is causing permanent damage to our eye. And glaucoma is also a risk when somebody has diabetes. This is something that we see a lot. We're always dilating patients to take a good look at their eye, at the back of their eye, looking for those things at the back, the nerve and the retina, but also looking at the front of the eye when we're seeing them. We are very fortunate that we have some newer technologies available to us, not just optometrists, but in other locations as well, that are taking images of the back of the eye to look at diabetic retinopathy. But remember, this is only one small piece of what we're looking for. So let's take a look at that. This is a wonderful tool for us to be able to find diabetic retinopathy in somebody's eyes. This image here is taken from an IDX-DR, which is one of the earlier instruments that would take an image and then use some AI to analyze it and then maybe send it off to an eye care specialist to take a closer look at it and make sure something is or is not going on. And this is the type of image that they would take. Wonderful tool to be able to use. However, if you think back to that image that I showed you of my eye, and here I'm going to pull up one from my colleague up in Grand Prairie, Dr. Giles, this image is going 200 degrees. If I pull up a little circle, you can see that green. The image on the left is 45 degrees, and I've highlighted that in that other circle there. So look at all the work outside of that the ophthalmologist has done. This is a laser that's been done in the retina to help with the diabetic changes in the eye and the diabetic retinopathy. And there's very little of it happening inside that circle. And so using that instrument, we would have not only missed what's happening in the cornea, the lens, and the optic nerve, because it's not looking at the optic nerve, it's looking at diabetic retinopathy, but we would have missed everything else as well. Now, in this case, there is one little vessel change that's happening, so maybe this actually would have been caught. And again, it is a tool, it's wonderful, but it is not the whole story. And we know the studies tell us that the cost effectiveness and the outcomes are all improved when optometrists are engaged in screening for diabetic retinopathy and the testing for diabetic retinopathy. And again, in part because we're not just checking for diabetic retinopathy. Okay, I'm going to get off of my little podium there. Let's talk about other systemic medications and the eye and what's affected. Now, this is a lot on one slide. I think I could go into, there's a few pharmacists joining us. I think that you could go and grab your entire list of medications that you have, and every single one of them would have somewhere on the product monograph some kind of ocular implication, dry eye, blurry vision, so on. It's just crazy that everything can impact our eyes. So again, I'm going to highlight maybe a few that we see more commonly, or a few that maybe have a bit more of an effect that we might want to watch for that could have a visual implication. So we're going to move our way through the eye. We're going to start at the front here at the cornea. Amiodarone, this is causing a change in the cornea, whorl keratopathy. Not necessarily enough for us to stop the medication, but it is something we're going to monitor, because if it gets to that point where it's vision threatening, we might want to change something up. Dry eye, this is one that could be caused by probably every medication that's out there. But anything that has high anticholinergic activity, like our antihistamines, that can cause an effect here. This is going to reduce our tear film production and destabilize the tear film. Any of our mood stabilizers and antidepressants, this is changing things as well. Of course, the neuronal signaling is changing, and that's going to change our tear production. Accutane diuretics, anything that's pulling moisture out of our bodies will be pulling moisture out of our eyes. So we're going to get some dry eye from that as well. Moving a bit further into the eye, accommodation is our ability to focus our eyes. So we look far away, our eyes are completely relaxed. You look up close, your eyes focus. That's called accommodation. So what affects that? Again, those anticholinergics that we talked about before, they can also affect our focusing power. They kind of change that balance between your parasympathetic and your sympathetic, and our focusing system needs that balance to be able to work effectively and efficiently. Psychostimulants, question mark. We think maybe there's an effect there. Again, think of the PNS, SNS kind of system, what's going on there, and how that balance is maybe changed a little bit, but for sure they cause a little bit of a dilation of the pupil and maybe some blurry vision there. Cataracts, we talked about the steroid impact of this. Angle closure glaucoma, so Topamax. If somebody is taking Topamax for migraine or for seizures, it actually changes the anatomy at the front of the eye and increases the risk of angle closure glaucoma. The same thing happens with hydrochlorothiazide, although I don't have it listed on here. If we move back to the retina, tamoxifen is a big one. So if somebody is taking this either as a prevention or afterwards a treatment for their breast cancer or other concerns, this is one that we can get actually changes in the retina. We get a buildup of different crystalline deposits. Hydroxychloroquine or Plaquenils, anybody that's taking that for any kind of concern if they have rheumatoid arthritis, this can also change the back of our eyes. This is in this case, sorry, we're seeing a damage to some of the posterior layers of the retina. Glynia, if somebody's taking this, so MS not only presents as a problem with the eye, but also this medication can cause problems as well. We can get macular edema from this one. If we move to the optic nerve, I talked a little bit before about the calcium channel blockers. Is this neuroprotective? Is this maybe damaging? We're not sure. Minocycline, the antibiotic, that can actually also potentially be neuroprotective, but it can also potentially cause increased intracranial pressure, which can then push forward and cause damage at the optic nerve. Sildenafil, Viagra, we've maybe heard of this one before. That non-arteritic ischemic optic neuropathy we were talking about with diabetes, that's one that can happen with Viagra use as well. And then our Ozempics, our Wegovy's, there was a lot of media attention to this a little while ago that the risk of same thing, NAION, is higher than non-arteritic ischemic optic neuropathy when we take these medications. Some of the newer studies are saying, hey, hold on, hold the phone. Is this actually just an association? Because remember, diabetic patients who are more likely to be taking these medications already have that increased risk. Or is this from the medication itself? And maybe as we're seeing more people on it for not just diabetic reasons, but maybe weight loss reasons, that will shine a little bit more light on this. So a little bit of a caution on that one and just something to be aware of. Last one, Fosamax. So if somebody's taking this, they've got their osteoporosis. This can cause an orbital inflammation, just everything super, super inflamed. The exact pathway, not really known of this. We don't really understand why that happens, but definitely something to be aware of. So there we go. Quick overview of all of the things that can happen in our eyes from the different medications. I just picked out a few of them here, but again, there are a lot that can happen. So if your patient is taking a medication, there's something going on with their eyes and you are unsure, we are happy to see them, happy to take a look and make sure that their eye is okay. All right, let's change gears a little bit. We are going to talk about emergency eye care. So this is everything. Pink eyes, foreign bodies, lumps and bumps. Let's get into it. Let's start with the pink eyes. This is the thing that we all see all the time. I've got a photo here of a classic bacterial conjunctivitis, the goopy, yucky, ucky kind of an eye. This is one that an antibiotic would work for. However, red eyes there's only like one little piece of red eyes that come from a bacterial infection. Viral infections, allergies, is it just a generalized inflammation from something, maybe a systemic medication that's going on? Maybe it's actually red not because of anything on the front of the eye, but because of something going on inside. Maybe it's a uveitis or a scleritis or an episcleritis. So this is where the optometrist has the technology and the tools and the knowledge and the know-how to be able to figure out exactly what's going on for that patient and get them on that treatment that's correct the very first time. Irritated and painful eyes, of course, that kind of fits in with everything else. And then the lumps and bumps. So they have a big bump on their eyelid. When that gets to be a bit more serious, does it turn into something like this? This photo says it's a preseptal cellulitis. I don't know. This one looks pretty serious, but definitely if it was a preseptal cellulitis, we're using oral antibiotics to treat that because our topicals are not going to be penetrating into the eyelid to treat it. And this is where we're really relying on our pharmacist colleagues to help us out a little bit. I look up the dosage for children all the time. And then even though I'm pretty confident, I still call and I say, hey, this is how much they weigh and this is what the dosage is. Can you make sure that this is okay for me? We're not dealing with the actual medication as you are every single day in and day out. Dry eye, we talked a little bit about this, but if somebody is really suffering from dry eye, we can get them in and we can check just on that one health issue that's going on. Eye injuries and trauma, of course, if somebody gets something in their eye, but if they have a scratch, but also any blunt trauma. Now, be aware, of course, take your use your best judgment. Is this something that can go to the optometrist or does it need to go to the emergency room? But if there's something going on, the eye has been bumped, we can get here. This is a picture of something called commotion. So this is a disruption of what's happening in the retina, and we want to monitor that. There's no treatment at this stage other than monitoring. We want to make sure it doesn't become a hole or a tear or something more serious, but we do want to know that it's there, and we do want to make sure that it gets better. So even a blunt trauma where the eye itself seems to be okay, we definitely want to be dilating this person and taking a good look back there, and that can be done on an emergency or urgent basis. Foreign body, so I work in airdrie, as you heard. We definitely have a lot of mechanics and other industries in and around us, carpenters. So I am taking metal and other things out of people's eyes all the time. We can, as optometrists, prescribe the medication that's needed afterwards. But also, sometimes things happen and we get some kind of liquid in our eye, and we have pH strips in the office to be able to make sure that we can flush the eye, get it back to a neutral pH, so that patient can get onto the road to recovery, and of course, prescribe any medications that we're needing. Any sudden changes in vision, this is loss, this is distortion, this is really blurry, anything that's going on. And then any other health concerns that there might be. So for example, shingles, this can affect the skin, but it can also go into the eye and it can affect the eye. If that patient presents to us, because sometimes it is the first thing that we see, I will start them on the oral antiviral, but then immediately send them off because I can deal with the eye, but all the other stuff that's going on is not in my wheelhouse. That is for somebody else to be helping this patient with, and then we can co-manage and make sure we're getting the patient the care that they need. We are very fortunate because here in Alberta, there is coverage towards the emergency or urgent eye care from Alberta Healthcare, and that is at all ages. It does not matter. So anybody can come in to see us and have some coverage towards that appointment from Alberta Healthcare. These types of appointments are for that single issue only. I say it that way because, let's say, for example, you guys have seen somebody, you refer them over to us. There are times when I'm going to do this exam, but I might need them to come back for a routine eye exam as well. Or maybe I actually, depending on what's going on, I might want to do a routine eye exam first. There is a lot that a routine eye exam tells us that these might not. Like, for example, with headaches, if a patient comes in and they've got headaches, health-wise, I'm going to make sure everything is A-okay. But then I need to check a little bit further. What is actually causing those headaches? And is there a visual reason? And for example, a prescription I'm not going to be doing in this type of appointment. I need to do a routine eye exam to know if there's a prescription that could be contributing to headaches. Sometimes we think of those headaches as being frontal or temporal when it's related to the eyes, but the back of the neck can actually be from eyes as well. For example, if any of you wear progressives and you're looking at your screen and you're having to tip your chin up all the time to be able to see your screen because the prescription's not right, you're actually going to end up with headaches at the back, and it's a vision issue, not anything related to your neck. No referral is required any time to see an optometrist, but it is appreciated. If you're seeing a patient and something's going on, it's wonderful to get that history from you to know what's going on, what treatments you might have done, and what's happened. Because as wonderful as our patients are, they don't always remember all of that information, and they don't always remember your name. So it's wonderful to get that information from you. We're going to talk about a referral form that's available in a moment here. We do have some specialty eye care available as well. So I do the neurooptometry, the vision therapy, the binocular vision using prisms and all kinds of other stuff to look at the eyes. This is the assessment, management, and treatment of how our eyes are working together and how they're communicating with our brain. This is super important because something like this, if a child is seeing like this, they would pass a routine eye exam. They might have 20/20 vision. They might have no health concerns. Everything is A-okay, but they might be really struggling in school because they're seeing like this. And I wouldn't be able to pay attention in school if this is how I was seeing. Myopia management. So we talked about myopia earlier, or nearsightedness. This has recently been designated the standard of care by the Canadian Association of Optometrists. So we're seeing more and more optometrists take this up. However, there are some clinics that have really, dived into this and they have that more advanced equipment, and they're doing myopia management in that little bit more of an advanced way. Advanced contact lenses. This is not your day-to-day, dailies, monthlies kind of soft contact lenses. These are typically rigid contact lenses or mixed rigid and soft contact lenses, or hybrid designs are what they are called. Typically, this is used for ocular concerns, whether they have a really, really high prescription, maybe they have the keratoconus, maybe they have severe dry eye, but there's a therapeutic reason that we're using these lenses. There are, I should say, some optometrists with a special interest in low vision. So this is when somebody has a significantly reduced visual field or very low visual acuity. So assessing them, seeing how they can help, what tools and technologies are available to help that patient. Cosmetic optometry, this is maybe a little bit of a newer place. I'm going to pull up the next one here too, which is advanced dry eye, because there's a lot of overlap here. These technologies and this new equipment that we have available in a more advanced way to treat dry eye, not just what I might do as a primary care practitioner, but that next step up. There's a lot of overlap here. We kind of discovered, oh, hey, I'm doing this for dry eye reasons, but there's this kind of cosmetic benefit as well. So there's a little bit of when the stuff is happening around the eyes, some practices are now doing cosmetic optometry as well. So when should you refer? If there is a systemic condition, a medication that might be affecting the eye, we want to take a look even if the patient has no symptoms. Urgent emergency care, definitely we want to be seeing those. If a child is having trouble in school or trouble with learning, if there are headaches, if there's a concussion or a TBI, or really if there is anything that you're concerned about that has to do with the eyes, please, 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 we are happy to see them. We are happy to co-manage with you. We actually want to co-manage with you because that's best patient care. We really want to take a look. Now, one quick thing I want to say, because this you kind of know maybe when to send an adult, but children can be a little bit harder because children don't always know when their vision is not what it should be. They've never seen any other way. They don't know how to describe it. So what might you look for in a child when you refer? If there's really early or really late walking, we think really late walking, really early, this could actually happen if the child has a very high far-sighted prescription. So the opposite, things up close are hard. If things up close are hard, I'm going to push myself off of the floor and get up and walk sooner so that I can interact with my world a little bit better. Squinting, but also opening really wide of the eyes are some symptoms. Closing one eye, turning ahead, or tilting the head, maybe holding things really close, with the little caveat that kids in general hold things really close. But if they're not able, if they really are upset about you holding things further back, if they rub their eyes, if they have a lot of headaches, if they're having difficulty with reading, writing, learning, schooling, anything like that. And again, same as with adults, if there's any systemic concerns that might have an ocular manifestation, we would want to be looking at that as well. What are the coverage, or what coverage do we have available here in Alberta? So let's kind of move in, start to wrap things up a little bit here. Alberta Healthcare has coverage towards routine eye exams for those who are 18 and younger, 65 and older. Alberta Healthcare has coverage towards emergency or single health specific exams for all ages. There's also coverage towards dilated eye exams for all ages, and coverage towards retinal imaging, photography, medically necessary visual fields for all ages. There's a little bit more coverage on this, but this is what's going to impact the majority of your patients. There was a recent change in all of this. This was called the Opto 35 Bulletin. So what changed? We used to have coverage towards partial exams for children and seniors. That it no longer exists. So for example, if we're doing a routine eye exam and we need to bring that patient back on another day to finish, then maybe they have a complex case, they can't sit still, something is going on with that patient, there is no longer a covered option for that patient to come back. But this does not change the frequency of routine eye exam coverage from Alberta Healthcare. Also, in addition to this, Alberta Healthcare no longer covers the routine eye exam and the dilated eye exam on the same day. So for our diabetic patients, for example, that coverage still exists for the dilated eye exam. It just has to be done on a separate day from the routine eye exam. The frequency of the imaging and the photography that we can do has also been reduced. So patients with macular degeneration or glaucoma, those other kinds of chronic conditions where we're seeing patients a bit more often, the frequency of this has been reduced. And the reimbursement for several of the things that we're doing has also been reduced. So, along with this, the biggest concern that optometrists have is that patients are going to avoid or delay coming into appointments, and that's going to mean that we have potential vision loss and that patient is not going to get the care that they need. Maybe there's more referrals being made elsewhere, which means longer wait times, a greater strain on our system, and we don't want that to happen. We really want patients to be able to access the care that they deserve and to have great vision throughout their lives. With these changes, we have seen that some offices, and it is up to the individual office, whether or not there is any kind of fee associated with the exam. Again, it is up to the individual clinic, and they'll be working with their patients to determine that. Ideally, we want to make sure that our patients get the best care, but having the best care also means incorporating the latest technology so that we can improve our patient care. And what's considered an eye exam, a basic routine eye exam from Alberta Healthcare, hasn't changed in the last 10 years, but in actuality, it really has. We're doing a lot more with a lot more tech than we used to. So, we see some changes from that, as you have all experienced as well. So, how do you find us? You know, you see something, you're going to send somebody over to us. The Alberta Association of Optometry website is a fantastic resource for you. Right now, there's a Find an Optometrist feature where you can search for a location and name of an optometrist. Coming soon will be a bit more features. So if you're looking, for example, for a wheelchair accessible clinic, you'll be able to do that. There are lots of other resources available on the website too, including how to refer. So if you go on here, no referral is required, but there is a form here that's either a printable form or referral pads that you can get to send patients over to us. And then again, we have your information so we can go back and forth. When we're co-managing, we really just want to make sure that we're getting you the information that you need, that we're getting the information that we need so that that patient has the best care. You know, everybody has slightly different reporting preferences. So if you're a family doctor, a nurse practitioner, or a pharmacist who's a dietitian who is seeing somebody, I'm missing lots there, but seeing somebody who has diabetes, maybe you just want to know, yeah, check mark, everything looks fine. Maybe you want to know the patient thought their A1C was this, that they did measure their blood sugar today, they didn't measure their blood sugar today. I see diabetic retinopathy. This is the grade that I'm seeing it at. I also saw keratopathy. I want to know, and all optometrists want to know what you want to hear from us so that you're getting the information that you want. We do have access to NetCare as optometrists. Not every clinic has it set up, but a lot of us can go onto NetCare as well and see what's going on. Yeah, we just want to make sure that we're doing everything we can for our patients. Again, there's that coverage note there. Just a quick note that routine eye exams do not have coverage from Alberta Healthcare when we're between 19 and 64. However, there is private coverage available. So a summary here. Optometrists, I like to call us again the family doctors of the eye care industry. We can prescribe all Schedule 1 and 2 medications, co-manage with all other healthcare practitioners. It's important to have routine eye exams for vision, for ocular health, for systemic health. This is a part of our overall well-being. Optometrists provide emergency and medically necessary care, and some optometrists provide advanced care in specialized areas as well. There is Alberta Healthcare. I didn't mention this before, but there is also social services and private coverage towards eye exams, and for social services, some towards glasses and or contact lenses as well. And you don't need a referral to send this to us. I have a lot of references here, so I'm going to just quickly pause on these, but then we're going to get to our questions. I'm going to just see if I can also pull up.
Hello. So far, we
Hello.
have no questions.
Oh, anybody have any questions?
While we're waiting, I just want to thank everybody again for joining us today. I can send the recording of today's talk in a follow-up email next week, so you can have access to it and potentially share it with your colleagues if there's something that you learned that you want to share. If you have additional questions that come up after, please send them to me, and I will drop my email in the chat so that you can have it, and I will forward them to Dr. Franco. And as you're logging off or when the webinar ends, please take a few moments to answer the survey. We really appreciate your feedback.
Thanks so much, everybody. I really appreciate you joining. I know that was a lot of information in a short amount of time, so hopefully you're able to keep up with us. And yeah, thank you so much. And you're so welcome. I'm glad I hope it was helpful for everybody.
It was a lot of information, but
I
an
know.
incredible overview. So thank you, Dr. Franco.
Yeah.
It doesn't look like we have any questions. Would you like to stay on just 2 more minutes just to see, or yeah,
Sure. Yeah, it's fine. Yeah.
we did get one thank you.
I see
Doc,
that. Thank you to that person. I don't know if I mean, I put some little jokes on here because I love a good punny slash dad joke. So, you know, if everybody wants to enjoy those jokes.
oh, I like your thank you slide.
Yeah.
I just noticed that now.
Yeah. Just so everyone is clear, I'm going to put my glasses on. Oh, Megan, you're so welcome. Other Megan.
Thanks for joining us.
Hmm.
I think we're good. I
All
don't know if there's room for questions. You provided so much information. But again, if a question comes up after, I dropped my email in the chat. So you can grab that and I'll be emailing everybody the recording as well. So you'll have it there and I can forward any questions to Dr. Franco. Oh, um, more thank yous. We
Oh, you're so
appreciate that.
welcome.
Thank you
You guys
very
are so
much.
wonderful. Thank you all. And I'm glad to hear, as a pharmacist that you have good interactions. I love that. I rely on all healthcare practitioners, but I probably contact the pharmacists and the family doctors and nurse practitioner the most often. So thank you. I appreciate you as well.
Thank you. Well, thank you everybody for joining us. I hope you have a wonderful rest of your day and a fantastic weekend.
Thanks so much, everybody.
Take care.